in cement. You know, you can talk about impaction grafting, cemented long stem, cemented revisions, cemented for infection. So I'm going to concentrate on cement and cement, which is probably my commonest revision of a femoral component. And I think it's the thing that says, if you do a cemented stem in a young patient and you need to revise it at 5 years, 10 years, 15 years, 20 years, 25 years for cup failure, you can revise the femur in 5 minutes. And Peter alluded to this stress shielding with cementless stems. A well-done cemented stem is revisable with cement and cement technique in about 5 to 10 minutes. Why is that not moving? Sorry, I've just got... Okay, so we'll come back to this, but here's a cemented stem. It's well fixed. It's become recurrently dislocating at 30 years, and the cup is incredibly well fixed. The stem's incredibly well fixed. What are people going to do here? And the short answer is most people in India would pull everything out, do a big uncemented shell and a big long uncemented stem. And as Peter was alluding to, that's not necessarily the right thing to do. So what is cement and cement revision? Does it work? Is it scientific? When do you do it and how should you do it? It's essentially the removal of a stem from the cement mantle to allow access to the cup to do a revision. And again, the Wrightington group and the Exeter group and us in Brisbane, we're very big fans of impaction grafting. Impaction graft your socket and then take 10 minutes to re-cement a stem back into the old cement mantle with some new cement. There's a lot of publications now to say it works. Many revisions in Exeter. It's done for periprosthetic fracture. It's done for all sorts of reasons, and the results are really, really good. And if you read the literature, the results for femoral cement and cement technique are excellent. And it's very rare to have to re-revise for femoral aseptic loosening. And based on the data and the literature and the evidence, we designed a series of stems for cement and cement revision, including the 44 00 stem. In Brisbane, we did a lot of work on the science of impaction grafting, including the strength of the bone cement interface and the cement cement interface. And by removing cement and re-cementing, your new bone cement interface is weaker than your original bone cement interface, but your cement on cement interface is actually the equivalent of the cement. It doesn't create a new interface. You can't find the interface unless you use very special techniques to look at it. So old cement and any cement, any PMMA, they have slightly different characteristics that Peter talked about with time to polymerize, but fundamentally they're the same material, and you can put any cement on any other cement and they will form an incredibly strong bond. We do it to gain access to an acetabulum. If you've got a monoblock stem with a damaged or incompatible head, you've got a modular stem with a damaged or incompatible taper, a broken stem, or even if you need to change component position, you want to change stem version, offset or leg length, you can take the stem out and within that cement window you've created, modify any of those characteristics. And it's super, super easy. It's actually easier than a primary hip because, again, Peter talked about back bleeding and pressurization and stem timing. Because the interface is already intact, you don't have to worry about any of those things. You can actually put your cement in early and it'll bond to the old cement, and you put your new stem down, and you're not worried about bleeding, you're not worried about having to really maintain high pressure, because essentially it's a dry cavity that isn't going to be at risk of blood in the bone cement interface. So here's a case. You can see the distal lysis, you can see the well-fixed cement. You can see my dad actually trained at Wrightington, and he was a Chinese disciple. He didn't use a plug, and he used to put cement halfway down the femur, and that would have been a long day at the office to try and take all that cement out and revise it. But yeah, I just exposed the implant, cleared the cement, and made a little cut, just to take 1 or 2 millimeters off the proximal femur. And if you looked at that, that would be a very long day at the office trying to remove that cement. That would be a really difficult operation. But people still, to this day, persist in removing all this incredibly well-fixed cement to put down a long, uncemented stem that, as Peter said again, is madness. You don't want to go long. You can revise this in a couple of minutes. That's the revision. You take the trial stem, you put it out of the femur, you do a trial reduction, you re-cement, and we've turned that into that, into that. And there's really no indication to remove well-fixed cement in a femur for revision. And interestingly, even the most strong uncemented surgeons in Australia now will do cement revisions if the femur looks like that. It's a bit like Russian dolls. There's always an exeter stem that will fit into a smaller stem. A 30, a 33, a 35.5, 37.5, a small 44. They're like Russian dolls. You can find one to put inside the one before. This is a video that may or may not work. Yep, going to work. No, it's not going to run. Sorry. But essentially, the stem was removed. There was a cement and cement acetabular revision. There was a cement and cement femoral revision, and the operation took 45 minutes. And I would say 90% of the room, plus probably 8%, would have taken everything out of that acetabulum and done a big uncemented stem with wedges and all sorts of drama. Would have taken all that cement out with a long uncemented stem of some description and taken 4 to 5 hours to do that revision. So you can see if you do a good primary cemented total hip replacement, the next operation is incredibly easy, the bone is incredibly well preserved, and you've created an environment for the next revision. That is a step forward. So please, 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 in the presence of a well-fixed cement mantle, do a cemented cement revision. Even if you don't want to do cemented hips in your primary, it's an excellent option that will decrease morbidity and gives really, really, really good clinical results. Very quickly, a couple of crazy cases. That's a cement and cement, very elderly patient, cemented and cement on the femur. You might not do that in a 20-year-old, you do that in a 90-year-old with a cemented dual mobility. This, again, big impaction grafting, cement and cement. So you can do some out there stuff, but you can do the basic cases really, really easily, and I'd strongly recommend the technique to you. And even your fractures, you can take the stem out, you can do a smaller stem. You can fix it with cables or plates, probably plates as well as cables. Thank you.